So welcome everyone. My name is Bert Scholl. I'm with the Cancer Resource Center of the Finger Lakes. Welcome to Living Well with Cancer, brought to you by the Cancer Resource Center of the Finger Lakes and the Cayuga Cancer Center, Cayuga Medical Center. Tonight's presenter is Dr. Garbo, and he'll be presenting on genetic testing for cancer. Who should be tested? So with that, Dr. Garbo, I hand it to you.
Well, thank you. Hopefully everyone can hear me okay. And once again, my apologies for being so late and having a problem getting Zoom on this computer. So I've been in Ithaca here for about 32 years, and I'm the one who's been doing the genetic counseling for our office, Cayuga Medical Center's CHOA office. I've been doing genetic counseling since about 2002, but I do need to tell you I'm not a genetic counselor. I do see about 100 patients a year for this. Our office sends off about 100 tests to various labs for this. Not everyone who's referred gets tested. It's not always offered, and not everyone who is offered it gets it done. This is the Commission on Cancer's list of who should be doing genetic counseling. As you can see, there's a number of folks who'd be certified for genetic counseling, but also at the bottom, there's two categories there: advanced practice oncology nurses or physicians with specialized education, and board certified physicians with experience in genetic counseling. Those are the two categories why I feel I find to do genetic counseling for folks. So I want to go into a few questions that I hope to be able to answer by the end of the talk. So how often is cancer genetic? You know, people have different thoughts. So we'll try to answer this for people. Is it most people? Is it just 1%? Is it somewhere in between? Second question we'll try to consider is if a patient with breast cancer has tested negative for BRCA1 and 2, is there a reason potentially to do further testing? You know, is that the only test we should do, or is there broader testing or newer testing available? Third thing I want to try to emphasize during this meeting, are there any downsides to testing? Or any of the following possible if you get tested? Can you lose your insurance, lose your employment? Are there emotional issues, uncertain results, false positives, false negatives? So we'll discuss each of these things as we go through. And then, does everybody with a cancer gene develop cancer? Or does only some of the people develop cancer? Our hospital has been a member of the Commission on Cancer since the 1980s, and we try to follow the Commission on Cancer guidelines, and we also try to follow national NCCN guidelines, which is the National Cancer Institute has designated certain comprehensive cancer centers as comprehensive cancer centers, and they're places like Memorial Sloan Kettering, Dana-Farber, Johns Hopkins, Mayo Clinic, Roswell Park, and they give us suggestions as to how to treat patients, how to work up patients, and you'll see a lot of NCCN guidelines as we go through this talk. This talk is not meant to counsel or suggest or not suggest counseling for any particular individual, but is to give information. And decisions on testing should be made only after discussion with appropriately trained individuals. So next slide. So I want to talk about genetics today, not genomics. Genetics is the study of how different characteristics are inherited, in this case, the predisposition for cancer. Genomics is the study of all of the organism's genes in their genome and trying to find every difference, no matter how small, contributing to that characteristics. In other words, the study of individual genes versus the study of the entire gene, all of the genes in an individual and the interactions between them. So what we're going to talk about today are germline mutations, meaning genetic mutations that everybody is born with and that are present in every cell in your body. We're not going to talk about somatic mutations, which are the mutations that occur after birth and the mutations that occur in the cancer itself and not in the person as a whole. This slide may look familiar to some people. It's from the American Cancer Society, and I bring it up for one reason and one reason only, not because I expect anybody to know these statistics or want to retain these statistics. But if you notice, the top half of the slide lists how often various cancers occur, about 1 million males and about 1 million females per year. Several of these cancers, for males, prostate, colon, melanoma, pancreas, and prostate, are ones that are potentially genetic. For women, breast, colon, uterine, pancreatic, melanoma, and ovarian. If you add those up, you'll see it's about half of all the cancers. And so we have about 2 million cancers in the United States every year. About half of them are at least potentially genetic. And for all the cancers we just mentioned, about 10% of the time, a genetic mutation will be the cause. And about 90% of the time, it'll be a somatic mutation in the individual, meaning it's not an inherited genetic syndrome that caused the cancer. So we've got about 10% of these individuals out of the 1 million with these particular cancers, or about 100,000 people per year will have a cancer related to genetics. In oncology, there's lots of times when we can target a treatment based on what mutations a cancer may have developed. But that's not what this talk is about, as I said. There's lots of situations where we can find an inherited mutation which increases cancer risks. And occasionally knowing this can also help us guide treatment. The best person in the family is always that person who's at highest risk. Lots of times I'm referred to a patient who has a relative with cancer who hasn't been tested. I'm glad in that situation, and other people doing genetic counseling would be glad in that situation, to assess the family likelihood of genetic syndromes and decide if testing is best for that family. However, we can do the best job if we're testing the person at highest risk. That's because the best person, if they're available, if they test negative, we can clear the whole family. Whereas if we find someone who's not the highest risk in the family, we can only clear that person and their children, and not their siblings, not their parents, not their uncles, aunts, cousins, etc. So we try to get the best person available. That person is at the highest risk, but sometimes that person might be deceased, out of the country, they might refuse, their doctor might not agree to test them, they might have no insurance. So sometimes we have to test someone other than the best person to test. So in terms of types of inheritance, autosomal dominant means you get a copy of a gene from each parent and you pass one on to, you get one that gets passed on to a child. So an autosomal dominant gene means that if your parent has a copy of the gene, you have a 50% chance of getting that gene. And that's what almost all cancer genetics is about, is autosomal dominance. Every single gene we're going to discuss, with one exception, is an autosomal dominant. An autosomal recessive means you need to get a copy from each parent. X-linked means it comes down the X gene and therefore can be passed by mother onto her son, whereas the daughters would not be affected because they would only have one normal, one abnormal copy. This is a typical family tree. In the middle of the slide, you'll see what's called the proband, and the proband is the person at risk. If you notice, we list who are first-degree relatives, which are siblings, parents, and children. We list folks who are second-degree relatives, which would be aunts, uncles, grandparents, grandchildren, nieces, and nephews. And the reason that's important is that sometimes it depends on which family member of yours is involved in terms of saying who should get testing and who shouldn't. So this is now a little bit complicated slide, and it's not truly a true slide for anybody's genes, but it's done for simplicity. So if you notice across the top, we list DNA bases, and 3 DNA bases will make 1 amino acid in the protein product produced in the cancer gene. So if you notice here, we've picked a very simple base. We've called it CAT because it's CAT, which are 3 DNA bases. It makes 1 amino acid, which in this case happens to be a histone. So if we're going along and everything's normal, we're making CAT, 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 etc. But what happens if on the bottom half of the slide, instead of just continuing to make CAT, we insert 1 extra DNA base, 1 extra nucleotide? Now, rather than going CAT, 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 we now go for the next one, ACA, and then TCA, 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 and every single amino acid from there on is abnormal. So that's a situation where we have a frame shift, and every single further amino acid produces abnormal. We know that's a problem in the gene. So this kind of goes over that in a little bit more detail. If the original gene, rather than being CAT, in this case happens to be UUA, we can have a frame shift as we just talked about. We're now going to make every single amino acid that follows be altered. We could change just one of the 3 DNA codons. In that case, we might change it to, rather than UA, CUA. That makes exactly the same amino acid because there's more choices than there are actual amino acids. So that would never be seen as a problem. Next issue is, what if we make it say, rather than UUA, GUA? That would make a totally different amino acid, and that may or may not be a problem. Sometimes if you just change one amino acid in the sequence, it causes a problem. Sometimes it doesn't cause a problem, and sometimes we don't know if it causes a problem. And we'll get back to that. Then finally, of the 4 times 4 times 4, or 64 base pair combinations, 3 of them don't say code the next amino acid. 3 of them say stop coding. If they didn't do this, we would only have one gene per, we'd only have one gene per chromosome. It would be very simple organisms, 23 genes, and we wouldn't exist. So you can terminate and make the sequencing stop too soon, and that's clearly a problem. So what's the accuracy of the testing? If we're going to do genetic testing, how accurate is it? Not every medical test is perfect. In fact, none are. If the percentage of time we have a false negative, meaning we miss the genes that we're looking for, is 1 or 2%. So that's about as accurate a medical test as we have. As far as false positives, if it's being done by a reputable company, and any company that's a CLIA approved lab should be reputable for this, their chance of having a false positive is less than 1 in 1,000. So that's fine to use those companies. In fact, one company that we use most often, Myriad Genetics, has a false positive rate of 1 in 50,000. You can't do any better than that. But you've got to be aware of some companies out there that tout the fact that, oh, our false positive rate's only 1 or 2%. Well, if it's 1 or 2%, and you have a person who has maybe a 10% chance of being positive for the mutation that we're looking for, 2% false positive, 10% true positive, that means for every 2 false positives, we've got 10 true positive, or 1 out of every 6 people that we're telling is positive truly isn't. And that's just totally unacceptable. We don't want people making life-changing decisions if we're going to be wrong 1 out of every 6 times. If we go back to the slide we saw before, this one here, if we've changed 1 amino acid, we don't know for sure if that's not a problem, if it's a problem, or if it's never been seen before in anybody else, or when it's been seen before in only a small group of individuals in the family, and we don't know if that family has, if it segregates out with who in that family gets cancer or not, then we call it a variant of undetermined significance. And if we're doing these really large, broad tests of 40, 50 different genes, up to 1/3 of the time or so, you'll have a variant of undetermined significance. Some people have a hard time accepting that. What do you mean I've got a problem in one of my genes and you don't know if it causes cancer or not? Well, most of those don't, and we can't go any farther. Only about 10% of the time, if there's a variant of undetermined significance, will eventually be found to be deleterious. The majority of times it won't. As I said before, we do about 100 genetic tests in our office every year, and we get written back by the companies that do the testing if they eventually find out if something's truly deleterious or not. And we get back maybe only 2 times a year when they tell us, hey, that person that tested years ago truly has a problem or truly doesn't. Most of these just stay undetermined, and most of them are not likely to be cancer causing. So if we do genetic testing, there certainly can be lots of psychological impacts. You're supposed to go through an orderly set of emotions, and trust me, people don't. You go through anger, denial, anger, bargaining, depression, acceptance, and who knows where you end up, and you may be back and forth all over the place. There's occasional times when you do genetic testing and you end up with non-paternity issues. So you have to be very careful before you order a test. And finally, you'd think if someone had a negative test, they'd feel a sense of relief. But sometimes if it's a family with really bad genetics, they'll have survivor guilt, like the person who survives a plane crash. You know, they'll say, why am I spared when everybody else, quote unquote, in the family has this horrible problem? Or occasionally folks who get a negative test will feel alienated from affected family members. They will, you know, they don't feel part of the family anymore when everybody else seems to have a genetic mutation. So there was a law that was passed in 2008 called the Genetic Information Non-Discrimination Act, or GINA. And it's very, very important if you're going to do genetic testing. This law was passed with broad bipartisan support at a time when George W. Bush was president. Both houses of Congress were controlled by the Democrats. something we don't see anymore in terms of broad bipartisan support. But it applies to health insurance and to employment. You cannot discriminate against somebody who has a genetic defect for health insurance or employment, except in the only exceptions are if you're employed by somebody with less than 15 individuals in the insurance plan, and also go through various government insurances outside of Medicare and Medicaid, insurances like TRICARE, VA, Indian Health Services, Federal Employees Benefit Services. But the important thing about this is that it does not apply to long-term care insurance, does not apply to life insurance, does not apply to long-term disability insurance. So if you can get those to an employer in adequate amounts, if you already have them in place, don't want them, don't need them, can't get them because of various medical conditions, that's fine. But somebody who doesn't already have cancer and who doesn't have other major medical problems should consider, should I have long-term care insurance? Should I have life insurance? Should I get those in place before I have genetic testing done? Because if you get genetic testing done first and then apply for the long-term care insurance or then apply for the life insurance, you'll find yourself either very highly rated or denied. The age at which cancer usually develops in general tends to be 60s to 80s. But because of the way cancer mutations work that are genetic, the average age is 40s and 50s and even sometimes earlier. This is for two reasons. One is cancer generally is a multi-hit phenomenon. Even with a mutation of the sort we're talking about, it's unusual to get cancer based on just one mutation to the cell. It typically takes about 4 mutations to turn a cell malignant. So if you've already got one mutation in every cell in your body, now it only takes 3 further hits. In addition, the mutations we're talking about are of cancer suppressor genes, and if you make a cancer suppressor gene not work, cancer is more likely to develop. So cancers tend to be at early ages with genetic cancers. Now I'm going to turn to a couple of special types of cancer genetics. I'm going to first go to BRCA and talk about breast cancer genetics, and later I'll go to colon cancer genetics. We can try to talk about some others, but these two are really by far and away the most common that we see. The BRCA genes, BRCA1 and 2, were first sequenced around 1994, 1995, and commercial testing became available around 1996 through the company we talked about, a company we've talked about before, Myriad Genetics. Testing became fairly common around 2004. Believe it or not, Myriad Genetics had actually patented these 2 human genes. Now, I'm not a lawyer, but I don't think you can patent my genetic material or anyone else's genetic material. And this case went up through the US court system, reached the Supreme Court in June of 2013. They said, patent all the testing techniques you want. You cannot patent human genes. And that opened the door for other companies to start doing testing. So other companies by about January of 2014 started doing testing. So Myriad Genetics now has 2 choices. They can either drop the price of their test, which they did not do initially but have done subsequently, or they could quote unquote offer a better test. The better test is not just testing BRCA1 and 2, but testing a whole host of genes, testing a wide panel of genes. By about 2014 to 2016, they typically were testing, say, 25 genes. Nowadays, most broad testing is more on the order of 45 genes. Going from 25 to 45 doesn't really add all that much. They're testing really rare genes. But what going from 2 to 25 does is that not all times when someone has a cancer genetic syndrome that causes breast cancer, ovarian cancer, other cancers, is it just the most common genes? A lot of times it's going to be one of these other genes, so that BRCA1 and 2 only account for about 60% of the time if there's a breast cancer gene. The other ones come from all of the other genes that are out there. So this is a very busy slide. I'm not going to read it to you or even go over all of it. I just put this up to remind myself of kind of talking about how often people get cancer with BRCA1 and 2. So the most common cancer to get with BRCA1 and 2 is breast cancer. And for women, that can be as much as 60, 70, 80%. versus 11 or 12% in the general population. The ovarian cancer risk can be as much as 40, 50, 60% in BRCA1 and as much as 20 to 30% in BRCA2. And that's as opposed to 1 or 2% in the general population. Pancreatic cancer risk also goes up. It goes up with BRCA1 to about 5%, with BRCA2 to about 10%. That's as opposed to 1% in the general population. And in addition, prostate cancer about doubles with BRCA1 to about 20% and goes up at least that high in BRCA2 versus 10% in the general population. And then also, there is a slight increase for male breast cancer with BRCA2. It goes up to maybe 7%. So males with BRCA2 start approaching the female risk of breast cancer of 11 or 12% in the general population, but they don't really go all that high. So we think of BRCA1 and 2 as being a breast, ovarian, pancreatic, male breast, prostate syndrome. In addition, women who have breast cancer from BRCA1 or 2 have a very high risk of a second breast cancer. They can have as much as a 30 or 40% second breast cancer risk. So all of those things are important in terms of determining who we should test to see if they have BRCA1 or 2 and other cancer genes for breast cancer. So this is the testing criteria. These come from the from NCCN, National Comprehensive Cancer Network I was talking about before. So the recommendation from them, and they're the most commonly used and what most insurance companies will agree to, is that any woman who has breast cancer by age 50, any woman who has a triple negative breast cancer, anybody who has more than one breast cancer, any male with breast cancer, any individual who has Ashkenazi Jewish heritage and breast cancer should be tested. In addition, if you have more than one family member with cancer, whether that's one with breast and one with male breast, ovarian, pancreatic, or high-risk prostate, or whether that's at least two with breast cancer, two with breast cancer under the age of 50, or 3 patients with breast cancer in the family overall. As I said before, the best person in the family to test is always the highest risk individual. The individual has breast cancer or other cancers, especially at younger ages, or has some of these other special characteristics. But if you can't test them, you also could test a first or secondary relative of anybody listed above. So sometimes that's who we end up testing because they're the ones available. They're the ones asking the questions. I think this is a very interesting and informative slide. This slide comes from a study of about 4,000 individuals who were tested to see if they had germline mutations for known hereditary breast cancer genes. And this slide tells me 2 things. One, only about half of the individuals in this study were ones who met these NCCN criteria. The other ones didn't, but they had breast cancer. As you can see in the upper right pie chart, 13% of the folks who had BRCA1 or 2 did not meet NCCN criteria. And in the left upper pie chart, you'll see that about 30% of individuals didn't have any of the cancer genes, who had cancer genes did not meet NCCN criteria. So maybe the NCCN criteria are not broad enough. But the other very interesting thing about this slide is the bottom half. If you'll notice there, meeting NCCN criteria, they found, 46 and 47 individuals with BRCA1 and 2, but they also found 39 with another gene called CHEK2, 28 with an ATM gene, 7 with a PALB2 gene. So there's lots of other individuals who have a genetic mutation for breast cancer who did not just have BRCA1 and 2. In addition to the folks who didn't meet NCCN criteria, there were even more who had these other genes. In fact, if you look in this particular study of 4,000 individuals with breast cancer, there were more individuals who had CHEK2 than who had BRCA1 and 2. So lots of other genes out there of significance. The thing to know about these other genes is, number one, is that they don't cause cancer very often as likely as BRCA1 and 2. So BRCA1 and 2, remember, had 50 to 80% breast cancer risk. These other genes might have a 20, 30, 40% breast cancer risk. The other issue is they don't necessarily cause the same variety of cancer. BRCA1 and 2, if you remember, were breast, ovarian, pancreatic, male breast, and prostate. But something like CHEK2 is mostly breast and colon. So, when one's doing genetic counseling, you talk about the common things. I typically will talk if it's a breast cancer family, an ovarian cancer family, about BRCA1 and 2, but I'll bring up CHEK2 as well, because it's a very common gene, and it's one that people don't necessarily think about, especially in the lay press, especially other routine medical individuals or primary care docs and things. They don't know as much about this other gene, which is very, very common and very important. So I just showed you the NCCN guidelines. Well, does everybody agree that those are the people that should be tested? Not really. So NCCN was as above. The American Society of Clinical Oncology, the Society of Surgical Oncology say any breast patient under 65 should also be tested. And the American Society of Breast Surgeons goes even further. They say any woman with breast cancer should be tested. And some of that goes back to this slide I just showed you, where we're missing individuals if we just use NCCN criteria. Some also question if anybody belonging to a high-risk group, such as Ashkenazi Jews, should be tested even without a family history. I hope the next slide is what I think it is. No. Well, let me talk about it because I don't know where that slide is. I apologize. So there are groups of individuals who are at higher risk for having these genes than others. The one that's most commonly known about is the Ashkenazi Jews. So there can be groups that have what we are called founder mutations, meaning a mutation gets into the gene pool at some point in the distant past. It causes problems after the typical age of childbearing and after the age of typical child rearing. And if you stop and think what that's been over the centuries and millennia, it's not what we have today in terms of childbearing. The typical age of childbearing would have been teens, late teens, 20s, early 30s. So if you have a problem that starts in the 40s, those children are going to be just as likely to reach adulthood and procreate down the road as somebody who doesn't carry the gene. So in the Ashkenazi Jews, there are 3 mutations of BRCA1 and 2, and there are also other mutations we'll talk about later. And for the Ashkenazi Jews, the founder mutations occurred for cultural reasons, but in the other groups, which I'll show you later, it occurred for reasons of geographic determinism. They intermarried in fairly small groups in fairly small geographical areas. Now, Medicare, oftentimes I'm not sure that I totally like their policies necessarily, but they've actually gone one step further than NCCN and than any of the societies we just talked about. Medicare will cover genetic testing in any individual with a personal history of prostate cancer, regardless of age, family history, or anything else. They'll cover any woman with an invasive breast cancer. They'll cover any patient with a history of pancreatic or ovarian cancer. So you can get genetic testing done if you have cancer, if you have Medicare, even if it doesn't meet the national criteria. This is ovarian cancer. Pretty much it says that any individual with ovarian cancer or any individual who has a first or second degree relative with ovarian cancer should be able to be tested for these genes. And this is a complicated slide. It's for prostate cancer. I won't go into it completely, but essentially it says if you have high-risk prostate cancer, meaning a high-risk Gleason/PSA score, or if you have metastatic prostate cancer, you should be tested. And anyone who has, in addition to prostate cancer, has a relative with one of these other cancers should also be tested. Or again, if first-degree relative or one of the above. So now I want to talk about if one were to be positive for BRCA1 or 2, what would we recommend to them? In terms of breast cancer, there are 2 different things that one can do. One thing that you can do is do bilateral mastectomies. The other is to do more careful screening. There's never been a randomized trial in a Western society, and believe me, they never will be, because you'd never get women to agree on a flip of a coin either to have their breasts removed or not. So if you're trying to decide which is better, bilateral mastectomies or more careful screening, the answer is you have to rely just on your gestalt, or you have to rely on mathematical models. And the problem is that they're mathematical models. They may be right, they may be wrong, they've never been proven. But the mathematical models suggest that maybe there's a 3 or 4% benefit to doing bilateral mastectomies over doing more careful screening, but we don't know for sure. So if you're going to do more careful, if you're going to do bilateral mastectomies, we know that that is effective in terms of reducing the breast cancer risk by about 90 to 95%. So a woman who has BRCA1 or 2 and has bilateral mastectomies will have her breast cancer risk reduced down to less than that of a general woman walking down the street. She'll be down to a 6 or 7% risk. And the reason bilateral mastectomies doesn't reduce breast cancer risk to zero is twofold. The first is very simplistic. There was also already breast cancer starting to form, and unfortunately, that you took the breast off too late. The more important reason is the breast is not a simple round mound of tissue that just sits on the chest wall. There is breast tissue up to the collarbone, breast tissue on the upper abdominal wall, breast tissue out to the axilla. So no matter how careful a surgeon is in terms of doing a bilateral mastectomy, they leave some breast cells behind. As far as when to do bilateral mastectomies, the first issue is whether it's BRCA1 or 2. With BRCA1, recommendation is if you're going to do it, to consider doing it by about age 35 to 40, because that's when the risk for breast cancer starts to rise. With BRCA2, more early 40s. About 60 to 70% of women who have BRCA1 or 2 will opt either at that age or a later age for bilateral mastectomies, but about 30% of them will opt for more careful screening. And more careful screening means you start screening for breast cancer at an earlier age than you would have otherwise, but in addition, you add in other modalities. So you start asking the women to do breast self-awareness at age 18. You ask them to do about twice a year seeing a clinical provider, physician, nurse practitioner, physician's assistant to do breast exams twice a year. You start doing radiographic screening at an earlier age, typically by about age 25. You add in MRI scans of the breast, and then you start mammograms at 30 rather than at 40. MRI scans are more sensitive. They pick up more breast cancers than will mammograms. The problem is that they're not more specific. So you end up with more false positives, more biopsies, more worries, but you also end up finding breast cancer earlier and having less late-stage breast cancers. And then mammograms start at 30 rather than starting at age 40. So that's what we recommend to individuals who are BRCA1 or 2 positive in terms of breast cancer screening. In terms of ovarian cancer, what we call ovarian cancer is rarely actually ovarian cancer. Almost all ovarian cancers actually start in the fallopian tubes, and it's truly fallopian tube cancer. So in terms of that, we recommend that a woman have some type of surgery once she's done with childbearing and once she reaches about 35 to 40 with BRCA1 and about age 40 with BRCA2. When I say some type of surgery, the standard surgery would be a laparoscopic same-day surgery removing both ovaries and fallopian tubes. But, well, as I said before, that would be a little more than what might be necessary, because we know that almost all these cancers are starting in the fallopian tubes. So some people are starting to consider whether just to remove the fallopian tubes at that age, leaving the ovaries intact so a woman doesn't become premenopausal at that early an age and still has the benefits in terms of bone and cardiac and other health of having the ovaries still intact, and then removing the ovaries at a later age. That's still not quite standard practice, but it's being done more and more. You can try to do screening for ovarian cancer. The problem is the screening is not very good. So we don't really recommend doing CA-125s and doing blood tests, tumor marker tests, and doing transvaginal ultrasounds, but some individuals still do that. It maybe we'll find ovarian cancer early half the time, but that means half the time we're still finding late stage ovarian cancer. If a woman still desires fertility, there are things she can do in terms of in vitro fertilization, preserving eggs, preserving embryos, and then use those later if she's not ready to have childbearing at the age when the recommendation is to remove the ovaries. If you do remove the ovaries in the fallopian tubes, you will find about a 90 to 95% risk reduction in terms of ovarian cancer as well. And the reason here is twofold, the same trivial reasons before that we mentioned for breast, that the ovaries were already, there's already ovarian cancer present. The more important reason is that the same cell of origin that formed the ovaries and formed the fallopian tubes come from a gland called the Mullerian gland. And the Mullerian gland doesn't just form the ovaries and the fallopian tubes, it also forms the abdominal lining in women. And obviously you can't remove the abdominal lining, so you still can get a cancer that underneath the microscope looks like ovarian cancer, same pattern of spread as ovarian cancer, and same response to therapy as ovarian cancer. So essentially it's extra ovarian cancer. This is a slide I mentioned a little bit before. This is as far as the Ashkenazi Jews. They have a number of different mutations that increase the cancer risk. They have the 3 mutations in BRCA 1 and 2. They have a CHEK2 mutation. They have other mutations in some of the colon cancer genes, all at higher amounts. So somewhere around 10% of Ashkenazi Jews will actually carry, maybe 8%, 10% will carry a mutation that increases the cancer risk for them. This is a list of this is a slide that shows just how many different genes they are that cause different types of cancer. So for breast cancer, as you can see, there's a whole bunch of genes in addition to BRCA 1 and 2. For colon cancer, there are a number of genes that on that first line, if you look at the 3rd one in through the 7th one in, those are the 5 genes that make up what we call Lynch syndrome. We'll talk about that a little bit more in a minute. If you notice back up in the breast cancer area, they didn't mention most of the Lynch syndrome genes, but they also do have a slight increased breast cancer risk. The other most common cancer with the Lynch syndrome is uterine cancer, and so most of those are, again, the uterine cancer ones. Unfortunately, for ovarian cancer, not only are there BRCA 1 and 2 there, but so are all those Lynch syndrome genes. And you can see a list of mutations for various cancers on this slide. Obviously, we're not going to go over each one. So the Lynch syndrome is a syndrome that increases the colon cancer risk. It's the one that increases the colon cancer risk the most. Believe it or not, this type of syndrome was actually first recognized by a physician way back in 1913, when there was a physician who was speaking to his seamstress. And the seamstress was telling him about all the cancers in his family. And he wrote it up, he published it, and it got long lost and forgotten until in 1985, Dr. Lynch noticed this correlation again, called it hereditary non-polyposis colon cancer, because a number of these colon cancers weren't just occurring in polyps, which is how almost all colon cancers start, but some of them were occurring in flat areas along the colon. So in the early 1990s, they got together in an international conference in Amsterdam and came up with what are called Amsterdam criteria to determine who might have this syndrome. By about 1993, 94, around the same time the breast cancer genes were being discovered, they found the first 3 out of these 5 Lynch syndrome genes. And routine screening started back in that era. Remember, this is before Genetic Information Non-Discrimination Act. So at that point, if you got tested, some people were reluctant not to. Some patients were deciding not to and reluctant to because they were afraid of a discrimination in terms of employment or in terms of health insurance. Over the last decade, we've recognized that the Lynch syndrome isn't a single syndrome, but each of these 5 genes have differing incidences of what cancers they cause. Some are much more deleterious than others. So what I did is this is the next slide that says who should be tested for colon cancer genes. And in 2 different situations. One is a situation where there's a family member or a person with colon cancer. That's at the top of the slide. The second are those families where, or those individuals where there's lots and lots of polyps. If you have the potentially cancerous down the road polyps, the adenomatous polyps, or some other rare polyps, as opposed to the hyperplastic polyps, which are not cancer causing. If you have at least 10 of the adenomatous polyps, you have to at least consider whether or not you should do genetic testing. If you have at least 20, there's a strong indication to do it. These lead to the polyposis syndromes more so than the Lynch syndromes, but again, increased risk for colon cancer. This is a very busy slide, and this is the worst of the 5 Lynch syndrome genes, MLH1. And the reason I bring it up is I want to focus on 2 things. I want to focus on the ages at which most of these cancers develop. And as you can see, the colon cancers, for the most part, the endometrial cancers, the ovarian cancers are occurring at an average in the mid-40s, and sometimes, therefore, they're occurring much earlier. The other cancers in this syndrome are mostly occurring in the 50s. But as you can see, Lynch syndrome genes don't just increase the risk of colon cancer up to as much as 50 or 60%. In uterine cancer, up to 30 to 50% in women, in ovarian cancer, up to 20%. But they also have an increased risk for cancers in the urinary tract, increased risk for stomach cancer, small bowel cancer, pancreas, bile duct, probably for prostate. They increase the risk of brain tumors, and they increase the risk for a rare type of skin cancer called sebaceous neoplasms, which are not in the skin itself, but in glands in the skin. So again, I just want to briefly talk about part of this slide. This is the indications for who should be evaluated for Lynch syndrome. And if you have someone with colon cancer before 50, if you have somebody who has a colon cancer at any age, it has a second Lynch syndrome type cancer. If you have someone who has a first or second degree relative with a Lynch syndrome cancer and has a Lynch syndrome cancer themselves, or if you have at least 2 first or second degree relatives with Lynch syndrome related cancers, or even if you don't have it yourself, if you're a first or second degree relative, mostly a first degree relative of individuals that we talked about above. In terms of colon cancer, if you test positive for Lynch syndrome, you should start having colonoscopies at age 20 or 25, and at least 2 to 5 years prior to the earliest family member with colon cancer. In addition, those are going to continue lifelong. In addition, there may be some benefit to taking aspirin if you have Lynch syndrome. Exactly for how many years and what dose is unclear. There's actually still studies going on in that regard. In terms of uterine cancer and ovarian cancer, there's not been proven reduction in mortality by removing the ovaries and removing the uterus. There is a reduction in the number of cancers that develop, but because you can oftentimes find uterine cancer early, at the time when there's any postmenopausal bleeding, it's not at all unreasonable to leave the uterus in place and then remove the ovaries then remove the uterus at a time when you first find an issue. In terms of ovarian cancer, it's individualized. A lot of times it will be done, but at what age is unclear, although some people tend to follow more of the same guidelines that they would in BRCA 1 and 2. In terms of stomach cancer and small bowel cancer, oftentimes they'll do upper GI endoscopies about half as often as they do for the colonoscopies. And as I said, this is for the worst Lynch syndrome, MLH1. The numbers aren't quite as bad for the other ones. The other very important colon cancer gene to talk about is something called FAP, familial adenomatous polyposis, which causes cancer at very, very early ages. It can cause cancer literally in the teens and 20s, and you see hundreds of polyps. And then there's an attenuated version of it, which is exactly the same gene, and for reasons we don't understand, causes less of an issue, even though it's the same gene. So lots and lots of different cancer genes out there. As I said, the panels we use these days most often are 45 genes on average. Typically, the testing can be done and come back in about 2 weeks. Most patients who have testing done, if they are appropriate for testing, will have it covered by insurance. The typical cost these days for somebody who doesn't have insurance, doesn't elect to have it sent through insurance, has it denied by insurance, has come way down from what it was years ago. Years ago, back in 2013, when Myriad Genetics was the only company doing the testing, remember I mentioned they didn't initially drop the price of their test. They were charging $3,000 a test. Nowadays, through reputable companies, the average price is about $250, and many of the companies have support for folks who can't afford the $250 to do it for even less. So if you look at some of their websites, you'll see that the average person pays out of pocket, if they're going to pay out of pocket at all, $100 or less for these tests. I think I'll stop talking and see what kind of questions there are out there.
All right, and perhaps we could take the screen sharing down. That way we can see you. Great. And again, if you have a question that you don't want to be on the recording, just say so, and I will pause the recording. Dr. Garbo, I have a question. You had referenced when we changed the amino acid in a sequence
Mhm.
and how what the question that came up for me is, what do you mean by when we change it? Is it like it's changed genetically or?
Yes.
Okay.
So I mean, for all the syndromes we're talking about, these are all ones that are almost always inherited. There's occasionally times when somebody, while they're still, very, very early in utero, has a mutation that affects all the cells in their body. There had to be a first person to have each of these mutations, obviously. So rarely, maybe 1% of the time at most, it's a mutation that occurred just in that individual. And then, the other 49.5% come from the father, the other 49.5% come from the mother. But these are all inherited mutations.
Okay. So the changing of it, you mean it's more along with what's passed down?
Yes.
There's a question says, do you know of any links between BRCA genes and retinal melanoma?
So BRCA does have a slight increase for melanoma in general. So the melanoma is increased by probably about 1% with BRCA versus what it is in general population. So in general, we say to somebody who is BRCA1 or 2 positive, you probably should see a dermatologist once a year, which isn't necessarily a bad recommendation for anybody. I'm not totally knowledgeable in this, but I'm not aware of there being a further increase in ocular melanomas versus cutaneous melanomas.
Thank you. Amelia, yeah.
I guess I have a question for you, Dr. Garbo, in terms of like if a patient is considering having genetic testing, even if you're not their oncologist, would they come to see you and ask, like, does it make sense for me to have genetic testing versus, like, do they ask the regular oncologist? Or I'm just curious.
So, if they're already an oncology patient, oftentimes they will ask the regular oncologist. Sometimes, if it's kind of a straightforward situation, like the BRCA genes, like the Lynch syndrome genes, the regular oncologist will just order the test. If it's something that's a little out of the ordinary, we didn't get into lots of other syndromes. There are syndromes that increase kidney cancers, there's syndromes that increase some other rarer tumors. If it's kind of questionable whether there really needs to be testing done because they're kind of outside of the guidelines we talked about, a lot of times the other oncologists in my practice will refer the patient to me and I'll talk to them. I probably talk to probably 100 patients a year, probably 2 a week, and some of these are patients who don't have cancer at all. Some of these are referred by, a lot of these are referred by their primary care physicians. They say, I'm concerned about this person who has, 30 polyps, or I'm concerned about this person whose father and mother, excuse me, not father and mother, it has to be the same side of the family, whose father and brother, both had colon cancer by age 50. So a lot of time, and then we'll say to that person, well, if it's your father and your brother who both had colon cancer by age 50, are either of them available? Are they around? We'd prefer to test them than you. If we can't test them, we will certainly test, the person at hand, but we'll get a much better, clearer answer if we're testing the highest risk person in the family.
That makes sense. And then the person's already been diagnosed, so it's not apt to cause as many of the other things like the anger and depression and all those other things, right?
Although sometimes it does, because now you're saying, oh, it's not just me, it's my whole family that's at risk. So sometimes they still get the emotional issues. Yeah.
And if there's someone who does not have cancer themselves, but they have a concern based on just where they lie in the statistics, do they ask their primary, does their primary refer them to an oncologist for an appointment?
Yeah, they would refer them to a genetic person who does genetic counseling, whether that's an oncologist, which I'm the person in this community, can be somewhere else, to an actual genetic counselor. Yeah, but they would refer them to someone who does genetic counseling. And like I said, most people in the community are referring them to me, but I certainly have no ego. I'm more than happy to have them referred to a genetic counselor in Syracuse, Rochester, wherever. Yeah.
Okay, great. I just wasn't sure if the primary could send in the test or if they need to send you then, but they send them to you first, or anyone who will do it for counseling and discussion and then go from there.
Yes. The company we most commonly use these days is Myriad Genetics. For certain special things, we do use other companies. The one thing you don't want to be doing is using the genetics from places like 23andMe and Ancestry and things like that. They're great for telling you where somebody came from, what someone's ancestry is. But they're the types of companies I was talking about before, where the false positive rates are way too high. And also sometimes they tout that they're doing testing and they're not testing the whole gene. They're testing the most common mutations along the gene. Because for BRCA1 and 2, you can have hundreds of different mutations along BRCA1 and 2. Same thing for a Lynch syndrome gene. So you don't want to just test, oh, here's the most common site for mutation. You want to test the whole gene to see if it's abnormal.
It's just a blood test, right?
Yeah, it can even be done on saliva. We typically do it as a blood test, not because it's any more accurate on the blood than on the saliva, but because there's a little bit more of a failure rate in terms of we get a call back from the company saying we couldn't do the test, start over, then we have to send the blood. So we just typically send the blood, but it's just as accurate on saliva as it is on blood. Well, I say saliva, cheek scraping, I should say.
All right, thank you. Yeah, Judith, I just have to unmute.
Thank you. Are all or most of these studied or listed mutations in tumor suppressor genes? Or are there more mechanisms of?
There's more most of these are tumor suppressor genes, but that's not the only mechanism.
But most of them are.
Most of them are. I mean, a lot of times some of them are in not tumor suppressor genes, but just in cell repair genes.
Mm. Okay.
Well, does anyone else have any more questions for Dr. Garbo?
I guess when you said that 10% of the cancers are directly genetically connected, right? So that means that there's a lot of other factors, right? Obviously, and we've read about them and we've learned about them. So even if you have a genetic predisposition, you should try to do the other things that will keep you as healthy as possible, right? I mean, that's the takeaway.
Absolutely. Even for folks who have a genetic mutation, you can reduce the risk of cancer somewhat. I wish I could tell you it was dramatic, but you can reduce it somewhat with diet, exercise, activity, avoiding tobacco, avoiding excessive amounts of alcohol, those types of things. And in addition, not only can you help the cancer that's already present by doing that, you also can potentially lessen the amount of second cancers.
Right.
And I just want to clarify, when I said that 10%, it was 10% of certain cancers, and I tried to list them off of that initial slide. So it's probably 5% of cancers as a whole, because there's some cancers that rarely are genetic. You know, lung cancer is rarely genetic. The only genetics I'm aware of for lung cancer, there's actually one province in China. Mind you, remember how big China is, 1.4 billion people. This province has, I think, 80 million people. So, you know, it's not like it's a little tiny province. In that province, there's a mutation that increases, that's passed on genetically, that increases lung cancer risk. But unless your ancestors come from that province of China, there's no inherited lung cancer risk. You know, so a lot of these other cancers are not inherited. So if you take, you know, this going over again, breast, colon, ovarian, pancreatic, melanoma, uterine, I may have missed one, but, you know, take those cancers, add them up, they're about prostate, I don't think I said, they're about half of all cancers. So it's 10% of those cancers that have a genetic risk, or have a genetic component in terms of developing.
Thank you.
Thanks. Anyone else? All right. Well, Dr. Garbo, thank you very much for your time and your presentation. And thank you everyone for joining us, and hopefully we'll see you next month.